Hello, thank you for joining us today. I'm Shelley Gunther, sonographer and clinical marketing manager at Clarius. I'd like to welcome you to today's live webinar, and what a way to end our 2024 webinar series. Joining us today are esteemed guest speakers, Drs. Søren Boysen and Serge Chalhoub. Now, today's topic is pulmonary hypertension in crisis. Can POCUS save the day? We'll have a lively debate about POCUS and whether it's a game changer for diagnosing pulmonary hypertension in the unstable canine patient. Now, before we start, I'd like to thank the Vet Show and NAVC for inviting you all to join us here today. You're among just under 2,500 veterinary medicine enthusiasts who registered for today's popular event. This webinar is race approved thanks to the Vet Show, so please do stay on for the full session to qualify for one CE CPD credit. And by participating for 50 minutes or longer, you'll receive an email from the Vet Show in the coming week to redeem your educational credit. Now, after the main presentation, I'll do some live scanning with my dog Mabel, a 6-year-old Wheaten Terrier. And at any time during the webinar, you can use the Q&A box at the bottom of your screen, and Drs. Boysen and Chalhoub will be able to answer questions during the live Q&A session after the presentation. So I'll be your host today, and I'm really looking forward to this presentation. I always learn so much from these two doctors. Now, I'll set the stage by sharing a paper I came across. It's a nice study from the Frontiers of Veterinary Science that describes the value of focused cardiac ultrasound, or FCU, to diagnose pulmonary hypertension and assess its severity. In the study, the authors talk about how moderate to severe precapillary pulmonary hypertension is typically associated with clinical signs and negatively impacts survival, and how prompt recognition of PCPH might benefit affected dogs, resulting in earlier intervention and possibly improving their quality of life. Using focused cardiac ultrasound assessments examining 5 different parameters, they conclude that moderate to severe precapillary pulmonary hypertension, that's a mouthful, can be detected with good accuracy by non-cardiologists. Now, we'd just like to put out a quick poll before we get started, just to figure out where everybody's at and get to know our audience a little bit better. Now, what do you see as the key advantages of using ultrasound in your practice? Is it for improved diagnostic accuracy? Are you even doing ultrasound at your practice? Or are you just looking to increase referrals? Just give you a couple of more seconds to complete the poll. 3, 2, 1. All right. Most people are using ultrasound, which is fantastic. And most of you are looking for improved diagnostic accuracy. So this is going to be great for you. So stay tuned. All right. So now I'd like to introduce our guest speakers for today. Dr. Søren Boysen is considered a leading expert in all things veterinary POCUS. He's the winner of the 2023 Jack Mara Scientific Achievement Award, Advances in Point of Care Ultrasound, the co-founder of the Veterinary Emergency and Critical Ultrasound Working Group, VECCUS. He's co-lead on the Veterinary POCUS Consensus Statement documents, co-developer of the Calgary Pleural Lung and Ultrasound Approach to the Pleural Space and Lung, and primary author of the original 2004 Small Animal FAST exam. He's currently employed as full professor at the University of Calgary, where he continues to do research and develop POCUS techniques. Dr. Serge Chalhoub also joins us from the University of Calgary, where he's been a faculty member of veterinary medicine since 2021. Dr. Chalhoub was the recipient of the 2021 and 2013 Canadian Veterinary Medical Association's Teacher of the Year Award, and 2015 University of Calgary Team Teacher of the Year Award, the 2017 Carl J. Norden Distinguished Teacher Award, and is a 2024 3M National Teaching Fellowship recipient, recognizing Canada's outstanding teachers. He's also authored and co-authored numerous scientific articles and book chapters on veterinary POCUS. So as you can see, we are in very good hands today. Gentlemen, I will hand the presentation over to you.
Thank you so much, Shelley. And hello, everyone. Welcome back. It's exciting to be here. I'm Serge.
I'm Søren.
And Søren, what are we going to be talking about today? Kidneys.
No, we're not going to talk about the kidneys. We did that once. That was enough. Once is enough when it comes to the kidneys. We're going to focus on pulmonary hypertension. and how we might use point-of-care ultrasound to help us come to a suspicion or a suspected diagnosis of pulmonary hypertension.
Wait, pulmonary arterial hypertension with point-of-care ultrasound? What?
Well, let's go through and see if we can sort this out and whether it truly is helpful or not.
Okay, well, triage. We got a dog coming in. It's Piccolo, 7-year-old female spayed French bulldog, comes in for acute collapse. I'm looking a little less stressed than usual.
I don't know. You look both confused and stressed there, but also came in with a 3-week history of cough, exercise intolerance, and increased effort to breathe.
Okay, well, that's already concerning. I'm starting to run in the opposite direction, but you know, hearing you talk over the years, I know we shouldn't do a full physical exam that last 2 hours, drink our coffee. We should do something called a what now exam?
So we're going with the triage exam, and we'll come back to that. We'll talk about triage POCUS, but let's look at our triage exam to start with.
Okay.
What do you think of our initial vital signs?
Well, that heart rate would be great if it was a cat.
Once again, is it a cat?
No.
Look at it. Does that look like a cat to you?
I mean, it does look like an alien from outer space.
So this is 168 in a dog. We are worried. Respiratory rate 48, temperature 38.
Well, temperature's okay. That respiratory rate's a little high, you know, but seeing that this dog is anxious and definitely effort, way more important, definitely seeing an increase in effort. Oof, I'm a little worried here.
All right, and so you should be. We'll look at the mucus membranes, capillary refill time. They both look okay.
Yep, and strong femoral pulses, happy. Oh, here it is. We got a grade 2 out of 6 left systolic heart murmur, harsh lung sounds of crackle, CERN. You know what? My preliminary thoughts just thinking about this. Hold on. I think this is we need to get some chest rads, send it to the cardiology service. It's 4:30 p.m. anyways on a Friday. I'm out of here. I'm going to be home for dinner.
Okay, so let's wind this back. What did we teach you 20 years ago when you were a vet student? Stable or unstable? Is this dog stable?
Did you teach me that?
I'm pretty sure I did, dude.
Oh, okay. The dog would be unstable respiratory.
All right, so I would agree with you. And in that case, do you want to send it somewhere away from your resuscitation area to a specialist in a different room or a different area of the hospital?
That sounds like maybe a bad idea.
This is a bad idea. Let's bring the machine to the patient. We do not want to get radiographs in this patient. We could stress this patient. In essence, don't make the walking dyspneic the walking dead.
Is that a song?
No.
Oh, okay. Well, okay, wait a minute. All right, let's back it up. You said unstable, right?
Unstable. Don't take x-rays. Don't stress it when it's unstable. Ultrasound for the assessment of our patients is very valuable.
So we have respiratory distress. I think you and I agree that that's one of our primary problems here, right?
I would agree. We've got respiratory stress. And the other big thing that we notice, if we look at the little summary down here, we had a history of sudden collapse.
Oh,
so
okay.
syncope is another big differential that we want to work up.
So hold on. Syncope probably has 622.6 different differentials that it could probably talk about for the next 48 hours.
Actually, no, I would say not that many. Syncope has a number of differentials, as you can see here. Not as many as you usually go through when you talk about your internal medicine cases.
Okay.
But yes, syncope, we can have multiple different causes, as you see here. Cardiac, vasovagal, situational or cough-induced, what we call tussive, collapsing trachea in that sense.
Yep, pulmonary hypertension, cardiac intracranial neoplasia, pericardial effusion, heartworm, and of course, neurologic conditions. Potentially this was a seizure. So that makes a lot of sense. Respiratory distress, though, you and I love this. I like it because it's relatively simple. There's like 3 categories.
Yeah, so we're going to start big. There's lots of smaller categories when you think about. We're going to think about cardiac, pulmonary, and pleural space as our big causes of respiratory distress. And then we'll narrow those down as we start to gather a bit of information.
You know what makes me really excited here? On all of these lists, CERN, on all these lists, we cannot blame the kidneys. Ha!
We are the kidneys. We are the kidneys. Turning the world a golden home. Yellow submarine, it was.
All right. Okay. In all seriousness, though, but obviously it's not the kidney's fault. Now, I'm thinking about clinical signs for pulmonary hypertension. Are there any defining clinical signs, something that's a go-to and a for sure thing?
Yeah. So if you go back and you think about those differentials we had, one of the big ones we were working up was syncope.
Yeah.
And not everybody associates pulmonary hypertension with syncope. Those two things don't always correlate.
Good point.
So let's look at some of the literature out there then. You can see this is a study by the crew out of Belgium.
Yeah.
If we look at this study here, when they get to severe pulmonary hypertension, they had 29 or 30 cases in this case.
Yep.
And if you look at the number that had syncope, they had 16 of these cases
Okay.
had syncope. So actually more than 50% of these patients had syncope.
But not 100%, not 90%, like 50%. So that's kind of the tough thing. And I wonder if that's a reason why we don't always associate it with pulmonary hypertension, is that a lot of other things can cause syncope. So let's look at other things here that we could talk about here. So other clinical signs, we have 2 studies here talking about different things. So syncope in that first study, the clinical features outcome, 25 dogs, syncope 64% with cough and just a little over half.
Yeah, so again, what was the most common cause reported in that particular study by JVIM? Syncope.
Yeah.
And if we look at another study, another one by the crew out of Belgium, they've done a lot of work on pulmonary hypertension. This is sort of one of the go-to centers for pulmonary hypertension in our veterinary patients. You can see again then, once it got severe, they only had 10 in this case what were severe, but they still had, or 20, sorry, but they still had 8 cases of syncope out of 20. So close to 50%.
Okay.
So syncope is definitely a common sign seen with our patients that are coming in with pulmonary hypertension. Something we should definitely be thinking about. Patient comes in with syncope, pulmonary hypertension should be on our list of differentials.
So pulmonary hypertension, syncope should be thought as together. So let's think about the classification of pulmonary hypertension. It's not as simple as we previously thought.
Yeah, this is where it gets complicated. And this is a nice paper. This is a very comprehensive consensus paper that came out by JVIM. And you can see that if you look at the classification, it's defined as an increase in pulmonary vasculature pressure. So that's pretty easy. Increased pressure in the pulmonary vasculature.
Makes sense to me.
Subgrouped into 6. And this is where it gets quite complicated. If you have to think about the 6, pulmonary arterial hypertension, left heart disease, respiratory disease, hypoxia, pulmonary thromboemboli, a big one that we tend to look for in the ICU in our critically ill patients. Parasitic disease, a bit unique to our veterinary patients compared to people, but diarrhea and angiostrongylis, and then disorders that are multifactorial or unclear. So 6 big groups. But there's a way to make this a little bit easier when it comes to thinking about pulmonary hypertension, because this could be a bit overwhelming when we're thinking about 6.
Yeah, let's divide it actually into 2 broad categories, pre-capillary and post-capillary. I know Shelley was talking about that in that paper. And both are associated with increased pulmonary arterial hypertension. It's an interesting way to think about it, because when we think about post-capillary pulmonary hypertension, what are the main groups that we're going to see in there?
Yeah, so we're thinking about those with left-sided congestive heart failure, or those that are unclear that still have signs of increased pulmonary wedge pressures or increased capillary pressures. So these are ones that are going to be left-sided heart failures. So this is a nice way to think about it then. Post-capillary, we're thinking about problems on the left side of the heart.
Right. Now, probably the most common group is going to be the pre-capillary pulmonary hypertension, and that's going to be all those groups except for group number 2. And in here, we have a normal pulmonary arterial wedge pressure, and there's a lot of different causes, which I've already outlined. Lung parenchymal disease, I think that's a big one we tend to think about. Hypoxia, thromboembolic disease, parasitism, et cetera, et cetera. So lots of different things. So, sir, what I'm thinking at this point is we stop already. We stop again. And I think it's time to do that rectal exam, which you denied me during that triage exam, and maybe do a CT MRI right now, 8 o'clock at night.
So did we decide our patient was stable or unstable?
I can't remember.
So our patient was very unstable. We had respiratory distress. We had tachycardia. We didn't have a patient that looked very good. So we are actually going to come back and talk about working up pulmonary hypertension in the unstable patient. So on the menu,
we're going to talk about the approach to pulmonary hypertension on triage.
Thank you. Triage being the big word there.
What POCUS can do for us with pulmonary hypertension.
What changes what we see with point of care ultrasound, and then we'll talk briefly, very briefly, on treatment and prognosis, because you saw how many categories there are. You can see that prognosis is going to vary tremendously depending on the underlying disease. So we're not going to spend a lot of time on treatment and prognosis, but we will touch briefly on it, particularly with regards to Piccolo.
So you're telling me that point of care ultrasound is going to save today? Live to POCUS?
POCUS to live.
Here we go. Absolutely. Look at that. It's no hocus pocus. This stuff is real. So let's go ahead and talk about it. So like you said, we don't want to do a whole bunch of different tests. This patient is unstable right in front of us. We want to do minimum emergency database. What do we got?
So part of our minimum emergency database, pretty common. We're going to get a systolic Doppler blood pressure, 126 millimeters of mercury in the case of Piccolo. Okay. We're going to put an ECG on, as we saw it as one of the causes or potential underlying contribution to syncope. We might have an arrhythmia.
Sure.
So ECG makes sense. There's our ECG. What are we looking at?
we're looking at here is sinus tachycardia. That looks pretty regular to me, just fast and nothing else spectacular here.
Correct. And when we're going to get a minimum emergency blood work, we often look at blood work. Maybe we've got an insulin or something that's causing our patient to be syncopal or collapsing.
Yeah.
So we do want to get that minimum blood work. But while that's being drawn and run, it's going to take a few minutes. What else can we do?
Well, that's the thing. I didn't think this was an ECG lesson. We want to do POCUS.
Live to POCUS, POCUS to live, live to POCUS, POCUS to live.
That's the cure for the Walking Dead, my friend.
All right, so it is true that point of care ultrasound is an extension of the triage exam. POCUS or ultrasound in general is an extension of the physical exam. When it comes to point of care ultrasound, we use it differently. We've talked about that in multiple other episodes.
Yeah.
But in this sense, we want the minimum windows to find the underlying problem. We want to use a triage POCUS, not take too long to see what the problem is, stabilize the patient, and then complete the ultrasound evaluation, just like we did with a secondary physical or something along those lines.
That's right. It's all about pretest probability. We have a patient with syncope. We should think that pulmonary hypertension is in there. So if we think about point of care ultrasound, we want to rule in or rule out pulmonary arterial hypertension. The big question I have for you is, in all the webinars we've done, it's a little more obvious, hit by car, painful abdomen. Well, we're going to go for the abdomen. Respiratory distress, high heart rate, murmur, etc. We're going to go for heart and lungs. What order should we start in this case?
Good question. And when we're looking at this patient, let's come back to pretest probabilities and our patient looks as part of that triage exam.
Yeah.
So we're going to focus on the big things that are most life-threatening. And if you looked at our patient and we look at Piccolo, what do you think was the most life-threatening concern?
Oh, I got this. Respiratory distress. Nailed it.
Nicely done. So that is a big one that we want to assess for sure.
Yeah.
But we also do have and know that we might see cardiac changes. We talked about it with with our left-sided congestive heart failure. We got crackles. We do have a murmur. So we do want to check that heart as well. We do have the concerns for pulmonary hypertension. We want to check the heart for that.
Yeah.
And then we do have the abdomen. And I'm not saying we should ignore the abdomen, but our patient does not indicate that we have a life-threatening intra-abdominal problem at this time.
Right.
So we're going to start with that, which is the most life-threatening. Therefore, we're going to start with the respiratory and then move through the system.
Yeah, I love it. So for reference, people can go back to our previous Clarius talks regarding pleural space and lung ultrasound. Plus, we actually had a couple of them. But essentially, we're using lung and pleural space borders that we're finding using
point of care ultrasound, and we're going to use our border-to-border approach. So we're going to use the pleural and lung ultrasound, the Calgary Plus approach. So we're going to start right behind that front limb and go through the different details here in this video.
Yeah, that's right. So we start right behind that front limb, and we consider that our cranial border, at least the most cranial that we can go to. And we know there's lung there, so there's no guesswork. And the probe is perpendicular to the rib. So we get our nice classic bat sign to find that pleural line and looking for lung sliding.
Yeah, and then we're simply going to slide caudal until we hit that caudal border. That's the curtain sign. Really nice thing to assess for pneumothorax or other pathology. Looks normal here, so we're going to slide dorsal till we come off the lumbar hypoxia muscles, then down till we just see the lung again. That, by using our borders, is the most sensitive spot to find air, for example, in a standing or sternal patient. That's our caudal dorsal site.
Caudal dorsal. We didn't count a rib to get there. We just use visualization of ultrasound and just figure out where our landmarks are. Okay, so from there, we're going to start scanning the lung in a big S-shaped pattern, going border to border to border to border, looking for lung surface pathology, biggest ones being B-lines and consolidations.
Absolutely. So we just simply jump a rib forward from that caudal dorsal site to hit the front limb, come down to mid-thorax and that behind that front limb, and then we slide caudal again, looking for surface pathology till we hit the curtain sign.
Yep.
So we're going to just separate the fur here, as you see, and there's our curtain sign a second time.
Yep.
Now we're going to follow that curtain sign cranial-ventrally
until we get down to the pericardiodiaphragmatic window. So essentially the lowest part for a sternal standing animal. We're pretending this animal's sternal standing. We're going to get the diaphragm, the actual diaphragm here, with the heart in the same window. And the reason why we can do that is because there's a mediastinal triangle of fat between the heart and the diaphragm. A little hard to see here because our patient is in lateral and the heart has fallen to the other side, but we have the heart and diaphragm in the same window. Then what?
And we're going to actually scan between the pleural border and the ventral lung border. So we actually turn the probe parallel and we scan from lung, ventral lung, looking for pathology in the lung, like you see here, and then down to the ventral border to look for pleural effusion. So we're using our borders and we're assessing multiple different regions in a very rapid manner. Any standing patient, we imagine our patient is standing in this case, just easier to show it in lateral.
Yeah.
And we look for different pathologies in a very, very short period of time.
Yeah, so on that patient, we saw a very nice, clean surface. We didn't see any beelines, those beautiful lightsabers that we don't want to see. That pleural line looked nice and smooth. And this is Piccolo. Whoa, sir, this looks completely different.
Yeah, this is actually quite interesting. If I look at these 4 different images, I'll ask you a few questions. Do you see vertical white rays of sunshine from the heaven, increased in numbers?
I don't see rays of sunshine, but I see an increased number of lightsabers. Yes,
Okay.
lightsabers.
Okay, so terminology is a bit controversial right now. Let's just agree to call them
Beeline.
vertical artifact.
All right,
Moving vertical artifact. All right.
Okay.
So you can see vertical white moving artifact. Agreed?
Yeah.
And what do you think of the pleural line in this case? Is it very smooth and regular in all our images, or is it starting to get a bit thick and irregular?
No.
Or are we starting to see some consolidations?
Well, I mean, it's thickened and irregular in most of these images that we're seeing here. It's really looks gnarly. And on the top right image, we can actually see a partial consolidation. That's actually quite concerning there, sir. These lungs are definitely not normal. I'm quite worried. But you know what? Hold on. Piccolo had a heart murmur. He's a small breed dog. I see a whole bunch of beelines. Boom, it's congestive heart failure. Let's bring out the furosemide. Whoop,
So
whoop.
again, now let's wind this back
Oh.
here. This is a very interesting thought process you've
Oh.
had. It wouldn't be uncommon to jump to that conclusion.
Okay.
But let me ask you a question. Uncomplicated left-sided congestive heart failure.
Yeah.
Do you think that pleural line is smooth or irregular and thickened with uncomplicated left-sided congestive heart failure?
You know what? I think it's usually very smooth and we don't usually get consolidations.
That would be correct. So let's look at a couple of papers. We're starting to see this evidence on the veterinary medicine as well.
Yeah.
But let's look at a few of the papers that came out. This is one from the human literature.
Okay.
And you can see they got acute cardiogenic pulmonary edema on the left,
Yeah.
acute lung injury in the middle,
Yeah.
and then they've got interstitial, let's call it aspiration pneumonia in our veterinary patients on the right.
Yeah.
Clinical course can be very similar between all 3.
Sure.
Presence of beelines can be very similar between all
Sure.
3. But this is where it gets interesting.
Yeah.
Look at the pleura in these 3 different disease conditions.
Yeah.
We can see that with acute cardiogenic edema, that pleural surface tends to be smooth, regular, and you don't see those subpleural consolidations.
Oh.
Whereas in the acute lung injury, aspiration pneumonia, diseases with inflammation, we'll often see that we get a thickened irregular pleura and we start to get consolidation.
Well, you know what's interesting too, Cern, is because small dogs, we're usually thinking about acquired left-sided congestive heart failure from mitral valve disease, and that murmur should actually be much higher. And again, like you said, now that pleural line wasn't smooth, even though we had all those beelines, so maybe it's less likely congestive heart failure.
Yeah, so less likely left-sided congestive heart failure.
Right.
Do we still want to scan the right side of the heart? We come back and we look at syncope and some of the history we had with Piccolo,
Yeah.
and we can see that we still have pulmonary hypertension and pericardial fusion on our list.
So wait a minute, you're telling me we should not rule out heart disease at this time?
We can say it's unlikely left-sided congestive heart failure, but we still should look at the heart. And not only should we look at the left side of the heart, let's also consider the right side of the heart.
Wait, what?
Let's consider the right side of the heart. And let's actually start with 2 different windows that we often look for, a right parasternal short axis and a right parasternal long axis views. What do we got here?
Okay, well, all the way at the bottom, right at the apex, we're just seeing the left ventricle. So this is not really helping us with the right side of the heart.
No, but as we start to move up, you'll see that we have the mushroom view, and then we see that we actually have the right ventricle, that little crescent-shaped moon, outlying and above that interventricular septum. So we got that right ventricle starting to come in at the level of the mushroom, just below the fish mouth view.
You know, what's interesting is because I don't feel like I usually look at that area. I'm usually looking at that left ventricle, and then getting the blah, 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 the fish mouth and looking for the whale and the Mercedes.
Yeah, and it's interesting because even if we go up from there and we get to that left atrial ratio, we can see the main pulmonary outflow tract.
Yeah.
On that right side of the heart.
Yeah.
So that is something we're going to come back to. So that left atrial ratio and a little bit above that, we can start to see that outflow tract. We can also see, like you said, the right ventricle at the level of the mushroom. So things that we should think about. And again, if you are interested, we did have a prior talk on focused cardiac windows in one of our prior Clarius podcasts.
Exactly. Now, what's interesting is that most of the time when you and I teach labs, we concentrate on short axis windows. They are easier to get. But if you really want to look at the right side of the heart, what we should come down to is come back to that mushroom, rotate 90 degrees, and boom, get our 4 or 5 chamber view of the heart.
Yeah, absolutely. So as you look down over here, you can see you got the right ventricle in the near wall because we're coming off the right side. So that's the right ventricular lumen we see here. This is the right atrium. Then we got the left ventricular lumen in the far field, and we got the left atrium in the far field. So we get that 4-chamber view, a nice 4-chamber view here. And this is very, very helpful when it comes to looking for pulmonary hypertension.
Yeah, what's interesting is you could tell this is not a cardiologist getting this. I mean, first of all, this is a microconvex coronary probe. We've got rip in the way. We've got some shadows. But again, for diagnostic purposes on triage using point-and-care ultrasound, that is going to be more than enough. But let's go ahead and show how we got these right parasternal short axis windows. So we can see our probe is at a 45-degree angle so that it can cut the heart in short axis windows, markers towards the elbow, and we have a beautiful mushroom here.
Yeah, and then from there, we're going to keep the point of contact on the chest or the thoracic wall the same. We're going to keep our angles the same. We're just going to fan the probe or tilt the probe until we go across that fish mouth view that you see there, and then we get that left atriotic outflow tract or left atriotic ratio and the outflow tract.
Yeah, what's interesting, again, this dog is standing, sir. We're not using a fancy schmancy echo table right there. We can do this on the fly in emergency. So that's our short axis windows. And then what about our long axis windows?
So from that mushroom, we're eventually going to turn 90 degrees like you see here. And when we turn our probe 90 degrees, you can see that we get that 4-chamber view. So we get the right ventricle, left ventricle, right and left atrium. And we achieve that by rotating our probe 90 degrees. And getting that long axis view.
So what's really interesting, Cern, is what I'm hearing from both of us is we're not cardiologists, right? We're not radiologists. We're not going to stop and do a whole bunch of fancy smancy measurements. We're going to be eyeballing a lot of these changes like we were doing on the short axis.
Yeah, we've talked a lot about the short axis, but let's now look at what should we assess, because we haven't done a lot of discussion on the 4-chamber view, but let's go ahead and look at what we should assess then when we're looking at the 4-chamber view, especially when we're looking for right heart changes.
Yeah.
So one of the big things we want to do, we want to look at the right atrium and the left atrium.
Yeah.
And they should be roughly
equal in size.
Absolutely. So we should have roughly the same size, right atrium, left atrium.
Yeah. And the septum between them should be neutral, which means it's not curved either way. It should be relatively neutral and flat.
And then if we look at the size of the right ventricular lumen, and generally speaking, it should be about a third the size of the left ventricular lumen. So once we start to get larger than a third, especially if we start to get half the size of the left ventricular lumen, we're really worried that we got some changes on the right side of the heart that are concerning. And the last one there, that right ventricular wall thickness for hypertrophy relative to the left ventricular wall. When it starts to get up to about half the size, 50%, the right ventricle gets to be about 50% the size of the left ventricle free wall.
Yeah.
Again, we worry that we have hypertrophy. Changes suggesting right-sided heart.
That's definitely a harder one to interpret, in my opinion. I think the other ones are easier to visualize.
I would agree.
So let's go back to Piccolo and see what we got. So we got normal there, and we're going to have Piccolo coming in shortly.
Well, let's just ask the questions real quick on this side. Okay. Left atrium, right atrium. I'll ask you the questions since we got them here.
Yep.
What do you think? Are they roughly the same size?
They look equal. All
right. What about that intra-atrial septum here? Do you think it looks
nice and neutral?
Doesn't have a big hammock sticking one way or the other? Nice and neutral. All right.
Nice and neutral.
What about that left ventricular, right ventricular? What do you think of that?
The right ventricle is definitely smaller than the left.
All right. It's about a third, I'd say. Not definitely not larger than that. And that left ventricular free wall, we look at it here.
Yep.
Oh, I just see if we get that. There we go. You can see it in the far wall here. We got the right, left ventricular wall and the right. What do you think?
Yeah, I think the left one is way thicker.
All right.
So I think we're good.
Now let's look at Piccolo.
All right, here comes the whoa.
So let's ask them one question at a time.
Ooh, I'm a little worried about this. So if I look at the 2 atria, that right atrium looks like it's ready to blow.
All right. So in terms of size, you would argue the right atrium is at least double the left atrium in this case.
Definitely huge.
All right. Definitely concerned. What about that intra-atrial septum? Is it nice and flat, like a 2x4 between the septum and the atria?
No, it's definitely curved towards the left atrium. I think you like to call that the, what do you like
That's
to call
going with
the
a hammock sign, because it looked like somebody could just lay right down there and have a nice nap between the atria and that nice hammock curve there.
You don't want to bring back this key slope?
No. We tried that once and didn't really work.
Fine.
So we're going to move on. Left ventricular lumen size compared to the right. What do you think?
I mean, that right is almost, if not probably bigger than the left ventricle.
I would agree. I think it's actually bigger than the left ventricle. Whoa, that's a problem. And then what about that right ventricular free wall compared to the left? Well, is it less than half
No, it definitely is. That right ventricular free wall looks thick.
All right, I would think it looks about the same thickness
Yeah,
as the left.
which is
So
concerning.
we've got 4 strikes when it comes to Piccolo, and we're looking at that right side of the heart.
Wow. But let's also look at that short axis also, right? So the intraventricular septum should curve toward into the right ventricle, semicircular shape, yes or no? We can see that in the normal dog.
Yeah, you look at this beautiful rainbow shape to that intraventricular septum, nice and curved. The whole left ventricle makes a beautiful circle. I come over and look at this one here, and whoa, looks like somebody's jumping on my septum, man.
No, it looks like someone's punching it. Look at that. Boom.
So we get a flattened intraventricular septum,
Yeah.
and if I look at that crescent-shaped moon on the normal dog, and I look at it over here, that's like a half a moon. It's almost Pac-Manning.
Yeah,
it's
almost
huge.
Almost a full moon there. That's a pretty big moon there. Okay, so that makes a lot of sense. Now, sir, I'm looking at this. I'm like, great. I think this looks abnormal. Is there a way for me to grade it with a score that helps me better interpret what's going on?
I think it was brilliant that Shelley brought up that paper that she found at the beginning there, because it fits so nicely to what we're going to talk about here. The crew out of Belgium has done a couple of studies. This is one of their earlier ones.
Yeah.
This is a 10-point. They did switch it to an 8 later, but we're going to talk about the 10-point scoring system because it's really nice to pull everything together. And you can see that scores higher than 5 had a and less than 2. So if you had less than 2, it ruled it out with a very, very high probability. If you had a score greater than 5, it tells you that you got pulmonary hypertension with a high specificity. So it's 90% accuracy overall.
Okay. So yeah, let's go ahead and look at parameter number 1. So right atrial, right ventricle enlargement, yes or no. So score 0 would be no enlargement. Score 1 would be one of the other enlargements. Score 2 is both enlarged.
Yeah, so I come back and I look at these 2 still images. I put them up here at Piccolo. You can see that we do have right atrial and right ventricular enlargement. Boom, he gets a score 2.
Oh my goodness.
So I like this scoring system. Very easy.
Not starting up very good
and
here
even
for
someone like you can add to 10.
I'm sorry?
You can add to 10.
With a calculator.
So this tends to work well. So we'll look at the next question then.
Right ventricular hypertrophy. Well, again, if we look at Piccolo, I think we're pretty clear that we had right ventricular hypertrophy.
Yeah, so this one's a little bit tougher because it also includes the prominent papillary muscles, and the definition of prominent, it does take a little bit of practice. So let's just say that we had the right ventricular free wall was hypertrophied. So we're going to go with a score of 1 in this case.
Right. Yeah, so it wasn't 0. We both agree with that.
Correct.
Okay. All right. So now moving on forward, what intraventricular septal flattening, yes or no?
And I like this because it's truly binary. It's either there or it's not. It's not a degree of flattening. Either it's flattened or it's not.
Yeah.
So we get 2 because, as you can see in the image to the top right, that still image there, we've definitely got intraventricular septal flattening.
Jeez Louise, that's really getting concerning. So now, what about right-sided congestive heart failure signs?
Yeah, so this is the one that they actually did a later study and said you're still going to be able to use the scoring system with or without the right-sided congestive signs.
Okay.
But I like the congestive signs because they have been looked at. We usually see them when it's a bit more severe or an advanced form of right-sided heart failure.
Yeah.
But you can see here that what are we looking for? We're looking for the presence of effusion or a distended non-compliant caudal vena cava.
Oh,
so still things that we can look for, and they did score them based on whether they had one or both of those present. So let's go ahead then. We haven't looked at the abdomen. We said we would.
Yep.
Our patient's sufficiently stable. Let's look at the abdomen and see what we find with Piccolo.
Okay, so let's start with the kidneys. We're going to go short axis, long axis, right kidney. No? Oh.
No, there is no place for the kidneys in triage.
All right, fine. So looking for right-sided congestive heart failure signs. Again, we're looking for abdominal effusion or ascites, distended hepatic veins, and a non-compliant distended caudal vena cava, potentially a halo sign. So we can see normal on the bottom.
Yep. So we got a normal picture down here. We got the gallbladder, diaphragm, the vena cava down there, very narrowed, collapsing, bouncing, and up here to the Piccolo, we got what? What do you think of that vena cava?
You can fit your head through there, Dr. Boysen.
So not moving much at all, very distended. What about that gallbladder? What are you thinking?
The gallbladder, I'm thinking we have a halo sign. Right?
Yeah, I don't know why you have a raccoon bouncing through there, but yes.
Raccoon.
So we got a halo sign. We got a thickened, So we got this thickened halo sign. So we got the halo sign coming in. Very nice. And what do you think about the abdominal effusion down here in the bottom left? You have abdominal effusion?
Yeah, definitely between the diaphragm and the liver, I can see some effusion, which is definitely abnormal there.
Yeah, and then you also start to see distended hepatic veins there as well. So very good. We're starting to see signs suggestive. I would say at least 2 signs that do support the evidence of right-sided congestive heart failure.
You really don't want to change it to the raccoon eye sign? Okay, so let's go back to our scoring system. And again, criteria number 5 is signs of right-sided congestive heart failure. And I think we can say an absolute score of 2 because there was presence of effusion and a distended non-compliant caudal vena cava. So that was concerning. So now that leaves us another category here, which, you know, honestly, I'm not very familiar with. Are we going to be looking at the pulmonary artery?
Yeah, and I think this is where the crew out of Belgium, Anne-Claire Merveille, Chris Gomerin, and their crew and their contingent had done a fair bit of work. And I do think the pulmonary artery is a great thing to look at when it comes to pulmonary hypertension. Everything in here is good, with maybe the exception, like I said, of the right side, the congestive heart failure signs in the abdomen. They tend to be a little less specific, and we don't tend to see them as nicely. But when it comes to the pulmonary artery, I do think that is something we should be looking for pulmonary hypertension.
Okay.
So how do we do that? We often start by finding the whale driving the Mercedes, that LAAO.
So we can do it in both short and long axis. So here we're going to start the short axis. We have a whale over here, which is left atrium, and the Mercedes, which is our aorta. Perfect. What do we do from here?
And then we're actually going to usually just fan a little bit until we start to lose that left atrium middle. You can see that over here on the right now. We've started to lose that left atrium. We start to see that outflow, the main pulmonary artery, a bit better.
Yeah.
So here we go. That's our aorta here. That's our main pulmonary artery here. We see the pulmonic valves coming in.
Yeah.
And we look at the ratio of that main pulmonary artery compared to the aorta. They should be roughly 1 to 1. What do you think here? Is which one's bigger, the aorta or the pulmonary artery?
Oh, the pulmonary artery, definitely. I mean, look at that length. Even I can tell you that.
All right. So now this is one of our signs of pulmonary hypertension, because that pulmonary artery is much wider or more distended than that aorta.
And that's pretty quick to do, because if you start getting confident getting that LAAO, I mean, this just requires a bit more fanning. It's basically deflating the whale.
Yes.
Okay, very cool. So now let's go through the long axis changes. Now, this one's a little harder for me.
Yeah, so a lot of us can get a 4-chamber view. We can get that right ventricle, left ventricle, right atrium, left atrium. So you see that here. And this is where we need to rock the probe to try and bring the atria in a little bit better and stay underneath that lung. So we got to try and rock that probe a little bit more so that we can start to pick up. And you just see it coming in here on this view here, this normal patient we had. You see the pulmonary vein. Which one goes into the atrium, the vein or the artery?
The vein is going to go.
Yeah, so it comes in long axis. You can see it coming into the atrium here.
Yeah.
And then you can see it on short axis right here.
Yeah.
At times, and it tends to be circular. And if you get up here on a still, this is from a different patient, just labels everything nicely. This is what you're looking for. You're looking for that pulmonary vein going into the atrium and that pulmonary artery on short axis. So that's the right pulmonary artery on short axis.
Yeah.
And that is our pulmonary vein going into the left atrium.
Okay.
All right. You got to stay below the lung. You got to rock the probe. You got to try and bring in the atrium nicely without the lung in the way so that we can see that image. And you may need to rotate a little bit more towards the 5-chamber view between the 4 and the 5 to sometimes pick it up.
Yeah.
And this is Piccolo that we see here. We also have a still image from an article, if you want to read up more on that, from Cardiology here, 2016, that you can see.
Yeah.
But this is our image here of Piccolo. And let's look at that pulmonary vein then compared to that pulmonary artery.
I can barely see the pulmonary vein compared to the big pulmonary artery.
Yeah, it gets squished and flattened between the right atrium and the pulmonary artery. And therefore, the pulmonary artery then is much bigger than the pulmonary vein.
Yeah.
And you can start to see that here. That's why we included the cardiology image, just because you can still see it's not fully collapsed. You can still see that pulmonary vein coming in. And it is, again, pulmonary artery much, much bigger. So I really like looking at this 4-chamber view. It was the crew in Belgium that showed me how to do this. And Claire Merveille, actually, the cardiologist there, showed me how to do this when I was visiting. I really like this. Having done that in Belgium, I've taken that with me. It's a really, really nice skill to be able to do.
So that is definitely more challenging. Again, it takes practice. You got to get that 4-chamber view and think about those little changes that we just talked about. But again, if we come back to our scoring system and come back to Piccolo, pulmonary arterial enlargement, artery enlargement, and the answer was an absolute yes.
Yeah, and if you look at the literature, this 10-point scoring system, again, they've gone to an 8-point as well, using the first 4 criteria.
Yeah.
But it still holds true. It's still going to be accurate. And in this case, we got a score of 9. We have a 90% accuracy that we are going to be dealing with moderate to severe pulmonary hypertension. That's the other thing we should emphasize here. This scoring system works very, very well for moderate to severe pulmonary hypertension. It doesn't tend to be as discriminatory for the less severe. So but we're worried most about the most severe.
Well, exactly. And like we said, we're talking about a patient population that usually had come in for syncope, right? So most of those patients are probably going to have moderate to severe pulmonary hypertension. Now, there's another way to look at this, and that's the eccentricity index for pulmonary hypertension. Take us through that.
Yeah, so this is another one. You did this on your short axis window, so you can see this is Piccolo on the left, where we got the heart in short axis and very distended right ventricle compared to the left. But then we're going to actually freeze this, and I've done so on the right. I made 2 still images in end diastole and end systole. Yeah. And it tends to work a little bit better in systole. You can do it in both, but it does tend to work a little bit easier in systole. Okay. Yep. So I do find it a little bit easier and a little bit more accurate in systole than diastole. Yeah. And essentially what we're going to do is we're going to get the width of the left ventricle, so the widest point, and the the height, essentially,
Okay.
and we're going to compare the two, and we're
Okay.
going to see how they look. And we should actually, if you look up here, this is the eccentricity index. We should have a value normally of about 1.1 to 1, pretty
Okay.
close to the same.
Yeah.
And would you say that the two are the same in this example down here with Piccolo?
Absolutely not.
Yeah, and once that gets to be more than 1.34, and in our case, we got 2.67, you can see that, again, it's sensitivity 67%, but specificity of 95%.
Wow.
So again, that eccentricity index, just another means by which we can double check or measure to see if we're starting to see signs of pulmonary hypertension or supportive of pulmonary hypertension.
Yeah, see, that seems to make a lot of sense to me. And again, it comes in that short axis window. So definitely something I think most people can do. So, whoa, so Piccolo probably has severe pulmonary arterial hypertension. We know he has syncope, clinical signs. What did we end up doing for him?
Yeah, exactly. So we gave some butorphanol for anxiety. He came in pretty anxious. We gave him oxygen, which is pretty standard. And then we used when we start to talk about pulmonary hypertension, we want to address both the underlying cause, try to find it and reverse it, because there are many, many causes, as we said.
Yep.
But we also do a general therapy, and a lot of our patients will benefit from specific targeted pulmonary arterial vasodilators like sildenafil. So we did start sildenafil in Piccolo, along with oxygen therapy and butorphanol.
Yeah, it's interesting. So sildenafil was actually created in humans to treat pulmonary arterial hypertension. But of course, during trials, they discovered this multi-billion-dollar side effect, which has made the company a lot of money. But hey, we still use it in veterinary medicine because it's relatively affordable, it works, and does not have that side effect.
In dogs.
Correct, in dogs. So improved in hospital, Piccolo was discharged. So we couldn't find a specific cause. We had an idea, but the reality is, in talking to our cardiology service as well, probably idiopathic pulmonary hypertension. But what was interesting is on the lungs, what did we see? Let's relate it back.
Yeah, so then we started to see that thickened irregular pleural line. And in this case here, we actually did suspect that we might have had underlying pulmonary fibrosis as well with Piccolo. So that's kind of what we were working with. Unfortunately, we did not go further with our diagnostic criteria. We did treat Piccolo. We did get Piccolo home. But again, overall prognosis in these cases?
Not that great, usually under a year. So they will respond to sildenafil therapy in terms of clinical signs. But yeah, that's pretty much it. And yeah, they declined referral at that point. I think they just knew how serious it was. So in summary, what are abnormalities suggestive of right-sided heart failure and pulmonary arterial hypertension?
Yeah, so we're going to come back to the paper, and there's actually a couple, 3 or 4 studies on that criteria, that pulmonary hypertension score now. But you can see one of the big ones, significant right atrium, right ventricle enlargement. When we see that, we should be thinking high on our list, along, especially if it's got syncope and signs that are supportive of pulmonary hypertension. We should be thinking, ooh, this could be a pulmonary hypertension.
Yep, an increased caudal vena cava diameter, decreased collapsibility index, and there was that big fat caudal vena cava that's not changing with respiration whatsoever.
Or other signs of abdominal congestion, effusion. So we might see that halo sign or ascites. Again, that one was a little less specific, and there are some studies. There was a study that was also looking at the caudal vena cava that didn't find it correlated well with pulmonary hypertension. But the other changes we're looking for, intraventricular septal flattening, for sure, we could see that. That's a definite strong indicator that we could have pulmonary hypertension.
Yeah, and pulmonary arterial enlargement, like we saw on that long axis view. Definitely think pulmonary arterial hypertension in that case. So that is all we have today. That was pretty awesome.
Yep, that was it. So it was pretty quick, but we do have a chance now to take a look at our volunteer puppy dog. I believe Mabel's going to pop in, and we'll be able to maybe take a look at our dog scanning live.
Sounds good. Take it away, Shelly.
Mabel is going to pop in. She's popped up already. So I'm using the C7 Vet scanner. And let's get Mabel standing here. Come on up here, girl. Turn a little bit. All right, now just gonna part the fur here, and we'll just kind of get right under her right armpit. Try to get the right parasternal view here. It's a tough one for me. Freeze. I've got my voice controls activated here, just so that because I've obviously got my hands are tied up. Increase gain.
You're doing pretty darn good by yourself there, Shelly. Look at that beautiful mushroom.
Great. Okay.
Mushroom, nice ventricle, nice crescent shape to it. That's all looking pretty normal.
Good. Yeah, and I can't use my pointer here, so just to point out structures, but I think it's fairly obvious here.
There we go. There's our intraventricular septum. There's our ventricular free wall, right ventricular free wall. There's our crescent shaped right ventricle.
That looks beautiful.
Great. So then if we want to just go fan up a little bit higher here, just to...
Fan. There's all that.
Beautiful LAO. Nice job.
Yeah.
All right.
We're going to have our outflow track off to the left of the screen there that you
Yeah.
just start to see on the left side of the aorta there. Yep. And then
Yeah.
between the pulmonary, yeah, you go. There you go. You can get the pulmonary valve starting to come in a little bit there. So you got a nice
Great.
1-to-1 ratio for the
Good.
pulmonary artery.
Nice job.
Boy,
Underneath.
thanks. Tiny little rib spaces.
Yeah.
Oh yeah.
Okay, and then if I want to get my long axis, I'm going to rotate my scanner here. And I'm just trying to make sure I stay within that rib space
Nicely
here.
done. Look at that. Left ventricle, right ventricle there. You can see the
Yeah,
mitral valves flowing into the left ventricle. That's the perfect long axis view there.
That's a lovely 4-chamber view. I agree.
Yeah.
I got the right ventricle in the near field, left ventricle in the far field. So
Left is bigger than
right ventricle's there. There's our left. They look good. We got the mitral valve just coming in a little bit under the lung. That's our left right atrium up here. A little bit of lung there, but a tough one to get.
In that rib space,
yeah, in that rib space with the dog in a standing position. But
right off the bat, just seeing that that right ventricle was not enlarged. I mean, that's already very encouraging to not think pulmonary hypertension.
And one thing I know from the human world is that when the heart is really enlarged, it's easier to see.
Yeah, totally.
So yeah,
100%.
Yep.
Yeah. Yeah.
Displaces the lung and gives us a larger cardiac window to assess our pathology. This is true. Same thing with pericardial effusion.
Yep.
Such a good dog. Mabel's
I know.
Amazing.
She's getting good at this, hey?
Yeah, totally.
Like, what? We're done? Aren't you going to scan something else?
I know. She's like, where's my cookie? There you go. Okay. Excellent. All right. So thank you very much. Again, like I said, I always learn so much when I have such good instructions. So to our audience, just a friendly reminder to stay on for at least 50 minutes to qualify for that CPD credit. And before we begin our live Q&A, I hope you'll stay on for a couple of more minutes here. We have a question for you, and this poll is an opportunity to learn more about our Clarius vet scanners. There are 3rd generation of wireless ultrasound scanners for your veterinary practice. So complete this poll to let us know if we can get more information to you about the scanners, and click on as many options as apply. The Clarius is available in over 90 countries now, and pricing and availability may vary by region. So please feel free to request a quote and pricing. And while you take a minute to participate in the poll, I'll tell you a little bit more about our Clarius Vet HD3 scanners for the highest definition wireless ultrasound imaging for small, medium, and large animals. Now, our C7 HD3 micro-convex scanner that I use today is specifically designed for clinical imaging in small and medium animals. It's got great abdominal, pelvic, and cardiac scanning. And now each scanner is designed to deliver the image quality and frame rates only found on traditional systems, but at a fraction of the cost. You're looking at about an 85% savings. Clarius is also wireless with the 0 footprint, which makes ultra portable for scanning animals anywhere they are, from the vet clinic to their homes. You'll have no wires getting in the way to startle the animals, which also makes it no wires also makes it much easier to clean and disinfect. And only Clarius delivers wireless scanners that come with an ecosystem that includes a free app for your iOS or Android device, with free updates as soon as they become available. And with membership, Clarius Cloud is available to save and manage unlimited exams and create reports. Your membership includes in-app Clarius classroom videos with experts like today's guests, as well as onboarding with a Clarius clinician to build your ultrasound scanning skills. And Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for advice or just a second opinion. Now, we have other vet scanners as well, a C3 convex vet for larger animals like sheep and horses, and the L7 linear vet for animal MSK imaging, great for equine applications, as well as ocular imaging. With increased ultrasound billings, you'll see a rapid return on your Clarius HD3 vet scanner. And one last thing I'd like to tell you about, we had a Black Friday sale that ended on December 2nd, but we've extended it to webinar attendees. So save big until Friday, December 6th. Now, the savings will vary by region, so please scan the QR code for more details here. All right, now let's begin our live Q&A session here. We have quite a few questions. I can moderate this. I have to put my glasses back on. All right. Okay, so the first question, what % of syncopes are caused by pulmonary hypertension?
Yeah, it's interesting. We were actually just Sarah and I were talking about these questions, and actually, I don't think that we know. And the problem is syncope is already a tough thing to really truly identify. I don't know that I know the number.
Yeah, no, I'd have to actually see if there's a specific syncopal paper, and then we can pull the incidence off of some of the research that's out there. But yeah, off the top of my head, I couldn't say what percentage of syncope is caused by pulmonary hypertension. But let me just flip that around from the standpoint of clinical value. If I get a patient that comes in with respiratory stress at rest, and it comes in with a history of syncope, pulmonary hypertension is high on my list of differentials. For sure it is.
Awesome. What is the pathomechanism pulmonary hypertension leading to syncope?
Yeah, so Stern and I also were talking about that. That was great. So I think it depends if it's precapillary, postcapillary. I think at the end of the day is, especially for the precapillary, there's going to be less oxygenated blood, right? So either that blood isn't getting to the lungs, or the lungs isn't doing the exchange, or whatever cause, but at the end of the day, there's going to be, on the flip side, less oxygenated blood, which obviously can then lead to the syncope. So that's the precapillary stuff.
Yeah, so exactly. Anything that can essentially decrease blood oxygenation and delivery to the brain can cause the syncope. So if you've got underlying pulmonary fibrosis or lung disease that's contributing to your pulmonary hypertension, you're going to likely have some oxygenation problems. You also get decreased return of blood to the left side of the heart, and therefore you get decreased cardiac output. That will also contribute to decreased oxygen delivery. So there's a multifactorial mechanism by which we can see it. And it does vary, as Sir said, based on the underlying cause. So, and if you've got left-sided congestive heart failure, again, then you can see how that can contribute to decreased cardiac output as well, and decreased delivery of oxygen to the tissues. So just think of it as all the different mechanisms when you're thinking of a pulmonary hypertension that can contribute to decreased oxygen delivery to the brain at both the level of the lungs and their function, as well as the cardiac output and its function.
Yeah.
Right. There's a question here about the caudal vena cava. Is there a normal range of size?
Yeah, so at minimum, we want to see a 25% change in width of that caudal vena cava in dogs, 20% in cats with respiration, so that's normal. And usually it's much more visible. So often, again, it's more of an eyeball thing. We see that change with respiration and change in diameter, and we're also going to get a cardiac pulse. And there's when the heart beats, we can actually see radiating on that caudal vena cava and seeing that pulse on there. So those are the normal findings. And often when the caudal vena cava is that distended, we lose that pulse and we barely see any change in diameter.
Yeah, and if it comes down to what's the normal size, it varies so much based on breed too.
Yeah.
So if you said what is the normal size, it's going to depend on the respiratory cycle. And we have looked at it. We actually did document the size in the study we did with the reference intervals.
Yeah.
But we tend not to rely so much on the size, because there's so many variations that can affect it in terms of abdominal pathologies, the degree of respiratory effort, etc. So we tend to use more, because then it eliminates the size factor. We tend to use more the change, because that is relevant to all size dogs or cats. So we tend to use the change in diameter with the respiratory cycle than an absolute size to the vena cava.
Yep.
All right. Now there's one question here. I think it's kind of mistyped, but I'll try to translate. Do these simpler measurements to measure the findings replace Doppler measurements enough to start treatment? So I think, yeah. Does that make sense? Yeah,
it's a very good question. Because when we're looking at the actual pressures, and we grade the pressures across the tricuspid valve when we look for regurgitation. So we're looking, or the pulmonary valve, when we're looking for regurgitation, we use the Bernoulli equation, and we measure the regurgitation for the pressures across that pulmonary valve. And what we find is those are the ones that we use to criteria to grade it. Like the gold standard is to actually put a Swan-Ganz in and measure your pulmonary artery pressure. Really invasive, not done. We rely on that pressure gradient Doppler to do that, and it gives us the severity. Does it replace it? No.
No.
Would I make a decision to start therapy in sildenafil based on the pulmonary hypertension scoring system and clinical findings that we can see with ultrasound?
Yes.
Absolutely.
100%.
So doesn't replace it?
No.
Not as accurate as it?
No.
But enough to start therapy with it, yes.
Yeah.
Okay.
So it does not preclude a referral to a cardiologist.
All right. Are there any variations when applying these scanning techniques for pulmonary hypertension to a cat or a horse or an exotic species like rabbits?
Well, that's a great question. I mean, to my knowledge, pulmonary hypertension is not really a common thing in a cat. Not at least leading to, not that I know about, honestly. And horses, I have absolutely no idea, or exotics also. Yeah, I'm sorry. That's a tough one.
Next.
Good question. Fair
question.
Yeah.
Yeah, that's a little outside our
Wheelhouse.
Yeah. So
Yeah.
if it's outside a cat or a dog, there's a chance we'll have scanned it.
Yeah.
Because we scan everything, but that
Yeah.
would be
Would you have clinical signs of pulmonary hypertension and diagnosis of pulmonary hypertension without all of these changes?
That's a good question. So I think in general, moderate to severe pulmonary hypertension is going to lead to some changes in clinical signs, I think in general. But there's no doubt there's been situations where I've seen cases in clinic where, we think it's pulmonary hypertension. There's some mild changes. We can't really find anything else. We treat for pulmonary hypertension and things do get better. So I can't say that everything fits all the time, but I would say for the ones with moderate to severe pulmonary hypertension, likely there's going to be changes and clinical signs.
Yeah, and I would also second that and say that occasionally we'll see a dog coming in with a milder form that does have syncope. So we do see that clinical sign with that milder form that doesn't result in all the changes that we see on ultrasound. So definitely the milder cases are tougher to correlate to the right-sided heart changes and things that we talked about today. They tend to be more obvious, as Sir said, when it's moderate to severe pulmonary hypertension. And those are the ones that we really want to identify early and start treatment on, because I think that's where our biggest impact on outcome and prognosis is going to be.
Yep.
This question is pertaining to Piccolo. Did the dog get some other medicine on the right side heart failure except sildenafil?
No, Viagra. Yeah, no, nothing. So we had discussed working up for pulmonary parenchymal disease, and potentially that could have led to some specific treatments, maybe slow down the disease. The reality is, if the fibrosis is already set in, not much we can do, but maybe there's secondary airway infections, inflammation, etc. The reality is we didn't do anything else, but the dog actually ended up rallying and doing okay on sildenafil. I think we got, what, 6-8 months?
Yeah, I believe so. I'd have to go back and check.
Yeah.
Yeah, we got about 6 months.
Would you generally see dry lung with pulmonary hypertension unless there is fibrosis, interstitial disease as an underlying cause?
That's a great question. So in our case, again, that's what raised the suspicion. Is this idiopathic, or is there pulmonary parenchymal disease that led to it, or are they two completely separate things, right? So in general, I mean, right-sided heart disease should not lead to any changes within the lung itself.
Yeah, and I think it depends on which group you're in, because we see a lot of if you look back at some of the groupings that you have for pulmonary hypertension, we see some that are secondary to decreased oxygenation in the lungs. So you get vascular changes. So we will see parenchymal lung changes that will result in pulmonary hypertension, and I'd expect those guys to have increased B lines. But do all cases of, or left-sided congestive heart failure, some of those guys are going to have those B lines.
100%.
So, but if you said, do all patients with pulmonary hypertension have B lines? No, we will see some that have significant pulmonary hypertension, grade 4, severe pulmonary hypertension,
clear lungs
that have perfectly normal lungs.
Yeah.
So you can see what the underlying variation is, how you get 6 groups. What you're going to find depends on which group you're in. So we definitely have some that will get B lines frequently, and some that won't have any B lines.
Right.
This isn't really a question, but a follow-up to the exotic animal question. It said most of these parameters, somebody obviously that has experience, have found are relevant for ferrets and rabbits, but getting good views of guinea pigs are extremely difficult due to their small thorax. Gotcha. Rats, huge problem with chronic pulmonary fibrosis, and I have seen the caudal vena cava and heart changes as well.
Holy tamale, that's so cool. I had no idea.
Yeah.
Thank you, Dr. Delaney, for contribution and input. We appreciate that.
Yeah. Love it. Love it. She says, thank you, and I love your lectures.
Look at that. Rats respond to sildenafil. Further follow-up.
Yeah.
Nice to know.
Yeah. Great.
I will know what to do next time I'm presenting at 4 in the morning.
All right. How much time do we have? One question: how common is pulmonary hypertension in dogs?
Probably not that common. So certainly not a high on the list of differentials. Even in school curriculum, I teach heart disease here. And the reality is it takes up a very small portion. The reality is also it's a vague condition. That's the problem, right? A lot of dogs have it and it develops late, it gets missed, they maybe get euthanized or have some other issues. So I don't know what the true frequency is. I don't think it's that high. It's certainly not, a problem that we see every week.
No, but I will also argue that I think with the advent of things like the pulmonary hypertension scoring system and the applications of ultrasound that we're starting to use in general practice outside the specialty hospitals, I do think we are starting to diagnose it more frequently than we would have, say, 10 years ago. And I don't know if it's necessarily an increase in prevalence, but a greater knowledge of how to identify it and look for it, and having the ability to do so. Because even 15 years ago, we used to have to send everything that we suspected of having pulmonary hypertension to the cardiology service. Now, I do think that it is something we can at least suspect or refer in, and maybe we're seeing it with a higher ability to pick it up. So it's not truly an increase in incidence, but an increase in ability to identify it.
Right.
So I think we're probably going to run out of time here pretty quick. So any questions we didn't get to, Shelley will email those to us and we will respond to you guys out there in the world with any questions that we didn't get to.
Yeah, for sure. And again, you're going to all receive a copy of the webinar recording as well by email this week. So just complete the closing survey to give us your feedback so that we can continue to bring you great educational content like today. Now, I'd like to conclude by thanking Dr. Boysen and Dr. Chalhoub, and also thanks to all of our furry supporting characters. And of course, thank you all so much for joining us today. I hope you had as much fun as we did. And we'll be taking these new skills back to your practice. And just remember, practice makes perfect. Thanks and goodbye.
Thank you, everyone.
Bye.